Good afternoon and welcome to webinar number 13 from New York Medical College and the Touro College and University System. This is Dr. Edward Halperin, the Chancellor and CEO of New York Medical College and the Provost for Biomedical Affairs of the Touro College and University System. And as I have been since January of 2020, I am your host for today's COVID-19 webinar. January 2020. We are now 19 months into these webinars and up to webinar number 13, trying to bring you the most up-to-date information about the pandemic, about clinical issues related to the pandemic, about public health issues and public policy issues. We hope you find all of our programs instructive, and we have another great program for you today. And as I always say, we got some old friends and we've got some new friends. We've invited Professor Bakshi back to join us to teach us all about the Delta mutation variant of the virus. We've got Dr. Schluger, the chairman of internal medicine at Westchester Medical Center and New York Medical College, to revisit yet again the controversy over hydroxychloroquine. And we're going to find out whether it really is still a controversy or not. The Dean of the School of Health Sciences and Practice, Dr. Robert Amler, is back with us to talk to us about whether we're going to all need booster shots or not. Dr. Mil Etienne is with us to talk about vaccine resistance and what we're, if anything, going to do about this nub of people who just won't seem to get vaccinated. As some pundits have pointed out, we now seem to have another version of two Americas, the vaccinated and the unvaccinated. We've got a new friend for you to meet, one of the executive officers of Westchester Medical Center, Mr. Joshua Ratner, who's going to talk to us about what it's like to run a hospital during the middle of a pandemic, and a return of a big hit from our previous webinar, college attorney, Mr. Nicholas Janaga. Last time he talked to us about the authority of a university to compel vaccination of its students. Now with some new court decisions and administrative law rulings, he's going to teach us about the power of an employer to mandate vaccinations on the part of the employees. Now, if you have questions for any of our panelists during today's program, type your questions in the question and answer box on your computer screen. We'll be monitoring them, and we'll get to as many of them as possible during the question and answer period at the end of the formal presentations. If you're looking for continuing medical education credit, we do offer continuing medical education credit for today's program, and I will appear on screen twice during the formal presentations to give you detailed instructions as to how to apply for your CME credit and how to answer your satisfaction questionnaire with today's webinar. Thank you for joining us, and let's begin our program with our first presenter, Professor Bakshi, who's going to teach us a little bit of the basic science of the COVID-19 virology and what we need to know about the Delta variant.
Hello, good afternoon, everyone. My name is Chandrasekhar Bakshi, and I am an associate professor in the Department of Pathology, Microbiology, and Immunology. And today I'm going to present an overview on the Delta variant and other viral mutations of SARS coronavirus 2, what they are and what we need to know about them. So I have no conflict of interest to disclose. So variant by definition means that it is a genetically distinct form of the main or the parent strain. And these variants arise as a consequence of mutations due to the viral replication. CDC has grouped these variants of SARS coronavirus 2 into three groups. So the first one is called the variants of interest, and this include 7 variants. So these are the variants with mutations that are predicted to affect the transmission, diagnosis, efficacy of vaccine, and therapeutics. The second group consists of 4 variants. Those are called as variants of concern. And these variants are the variants with the evidence of increased transmissibility. They cause more severe disease or increased hospitalizations. And they have the reduced effectiveness against the treatment, vaccines, and the diagnostic tools that are currently available. The variants of high consequence are the variants that have the demonstrated evidence of significantly reduced efficacy against the current countermeasures such as vaccine and therapeutics, as well as diagnostic. Fortunately, there are no variants of high consequence have been identified so far. So let's focus on what these variants of concerns are. So these are the four, as I said, four variants of concern categorized by CDC. Initially, these variants were named based on the lineage of the SARS coronavirus 2 as with the letter B or P, or from the country they were identified. But it was very stigmatizing for the countries as well as the citizens from which these variants were identified. So based on that, actually, now the World Health Organization has come up with this naming scheme using the Greek letters, alpha, beta, gamma, delta, and so on. So now these variants are named as alpha, beta, gamma, and delta. So the alpha variant was initially identified in the United Kingdom, and later on it was detected in the United States in December 2020. And this is the most dominant or the predominant variant of SARS-CoV-2, and it has been reported from 173 countries. The beta variant was initially identified in South Africa in December 2020, and then later on it was detected in the United States in January 2021. And this has been reported from 122 countries. The gamma variant of SARS-CoV-2 was initially identified in travelers from Brazil in Japan in January 2021, and it was also reported from United States in the same month, and it has been reported from 74 countries so far. The Delta variant was initially identified in India in October 2020, and it was detected in the USA in March 2021. And it has been reported from 110 countries, and this variant is spreading really fast. And this variant was categorized as the variant of concern by CDC very recently in June 2021. So in the next few slides, what I'm going to show is like how these variants, especially the alpha and delta variant, they differ from the parent SARS coronavirus 2 with regard to their transmissibility, disease severity, their efficacy against the currently available vaccines, and responsiveness to therapeutics. So as far as the transmissibility is concerned, the Delta variant is 40 to 60% more transmissible than Alpha variant. And just to remind that Alpha variant was in fact 50% more transmissible than the original SARS coronavirus 2 that initiated the pandemic. So this Delta variant is spreading very rapidly, and R0 value, which denotes the transmissibility of a virus. So the R0 value for the original SARS-CoV-2 was only 2.5, but for the Delta variant, it ranges from 4 to 7. So if we look at the circulation of the lineages of the different variants of SARS coronavirus 2, so this was the picture on April 10th. So the predominant circulating lineage was Alpha variant, and it was responsible for causing 59% of the infections, followed by the Beta lineage, the Gamma, and the predominant or the prevalence of the Delta variant was only 0.1% on April 10th. Moving fast forward to the recently available data from CDC on July 3rd, Delta variant has outcompeted the other variants of SARS-CoV-2, and now it is responsible for 58% of the cases that are being reported. Whereas the contribution of Alpha variant is reduced to 25%, followed by Gamma and Beta variant. So if we look at the regional distribution of these variants, and especially in those areas where the vaccination rates are low, there is a very high incidence of a Delta variant is reported, and it goes up to 70 to 80%. So basically, the bottom line is the Delta variant is a super spreader variant of the SARS coronavirus 2. So what is the severity of the disease that is caused by Delta variant? As we recall, the Delta variant caused a very ferocious wave of infections in April and May in India. However, the association of the Delta variant with the disease severity is not yet fully established, and we need more data to build a connection between the disease severity and the Delta variant. However, this study, which was conducted in Scotland, has shown 85% higher hospitalization rates in unvaccinated individuals that are infected with Delta variant as compared to the Alpha variant. So the bottom line is the unvaccinated individuals are still at a very high risk of infection with Delta variant. So what is the efficacy of the currently available vaccines against the two predominant variants of SARS coronavirus 2, that is Alpha variant and Delta variant? So the study that was conducted in England has compared the vaccine efficacy of two vaccines, that is the Pfizer vaccine and AstraZeneca vaccine, after a single dose or two doses against the Alpha and Delta variant. As we can see here, that the vaccine efficacy of both Pfizer and AstraZeneca vaccine, they are kind of similar against Alpha variant, but it goes markedly down or is lower against the Delta variant. And this was taken 14 days after the first vaccine. However, the Pfizer vaccine is still capable of reducing the risk of symptomatic disease by 88% after 2 doses of vaccination, and reduces the risk of hospitalization by 96%. So this vaccine is still effective. And with the AstraZeneca vaccine, modest differences in the vaccine effectiveness are observed against the Delta variant. So it is about like 60 and 93% respectively. So again, this tells us that the best way to protect against the Delta variant is to have a 2-dose vaccination. So what is the efficacy of the Delta variant against the currently available therapeutics? So it's been shown that the Delta variant escapes the therapeutic monoclonal antibodies, especially this particular monoclonal antibodies, bamlanivimab. So this has lost antiviral activity against Delta variant. And this is true for other variants also, which have this particular mutation, this L452R in the spike protein. However, the other emergency use authorized monoclonal antibodies, they remain active against Delta variant. And again, unlike Alpha variant, this particular study has shown a decreased efficacy of the polyclonal antibodies, which are induced as a result of a previous COVID-19 infection or vaccination. But still, we need more studies and data to show that indeed the efficacy of the polyclonal antibodies, which are generated in naturally infected individuals or as a result of vaccination, is reduced against Delta variant. So just to summarize what I have told you today is that the Delta variant of SARS-CoV-2 is more contagious than any other variants. And Delta variant could cause severe outbreaks in areas with low vaccination rate. So basically, the unvaccinated individuals are still at a high risk of becoming infected with Delta variant. And the best way to prevent or protect against Delta variant is to have 2-dose vaccination. And Pfizer vaccine and the results with Moderna and J&J vaccine have also shown more or less the similar results. So I will stop here and thank you so much for your attention.
Hello, this is your host, Dr. Edward Halperin, to tell you how to get your continuing medical education credit for those of you who are seeking CME credit from today's webinar. There are 3 ways to do it. You can text the code 90 KYAK, 90 kayak, KYAK. Text that code to 828-295-1144. If you send that text message, you'll get a response back with links and instructions as to how to fill out your satisfaction questionnaire with today's program and how to get your CME credit. If you don't like using that technique, go to the website www.eeds.com click on the sign in button and similarly put in the code 90KYAK. And once you do that and click on the button, you'll get information for the questionnaire for your satisfaction with the webinar and your CME credit. If you want to use the high-tech technique, get that cell phone or iPad out with your app, scan the QR code, and you will similarly be taken to the correct site to get your credit. These codes will all expire on Monday, July 26th at 12:30 in the afternoon. So may I suggest you do your CME credit promptly, lest you forget. Also remember throughout our program, if you have any questions for our panelists, please type them in the question and answer function on the bottom of your screen. We'll be monitoring them throughout the webinar, and we'll get to as many of the questions as possible during our question and answer period. Let's go back to our program.
I'm Neil Schluger, Chairman of the Department of Medicine at New York Medical College, and I'm going to speak to you today about the use of hydroxychloroquine for COVID-19 illness, a therapy that is gone, but apparently not forgotten. I have no conflicts of interest related to this presentation. Hydroxychloroquine came to attention very early in the COVID-19 pandemic because of some early reports from France and China of its effectiveness in the treatment of patients with COVID-19 illness. These studies in general were quite small, generally not designed with a great deal of rigor. There were no large randomized controlled trials that were done early on, and many of these studies were poorly conducted with lots of missing data and incomplete information. Nonetheless, because of a dearth of therapies, hydroxychloroquine and chloroquine, anti-malarials, were recommended by many hospitals and professional societies for treatment of COVID-19 illness, and they were widely used. Hundreds of thousands, if not millions of patients early in the epidemic received these therapies. A group that I led published the first large study looking at the effectiveness of hydroxychloroquine, and this was an observational trial, not a randomized controlled trial, of just shy of 1,400 patients. We found no association between administration of hydroxychloroquine with a beneficial outcome in patients who had COVID-19 illness. And this paper was really the first large-scale study that suggested perhaps that there was no effect of this medication. Shortly after our paper was published, a series of medium-sized randomized controlled trials were published looking at the use of hydroxychloroquine in a variety of settings, prophylaxis for people who had been exposed to COVID-19 illness, or some patients with mild to moderate disease. And these studies, randomized controlled trials, as I said, published in very good medical journals, found no effect of hydroxychloroquine and no utility in achieving a good outcome. A very large study out of the United Kingdom was then published in the New England Journal of Medicine. 4,700 patients were looked at in this study who were randomly assigned to receive either hydroxychloroquine or placebo. And this study also found no effect of hydroxychloroquine on mortality. More recently, in the Annals of Internal Medicine, just about a month or so ago, a study that looked at not only mortality, but the rate at which virus was cleared from the lungs in patients who received hydroxychloroquine was published. And this study, again, found no impact not only on mortality, but no impact on the rate at which the virus was eliminated from the body in patients who received hydroxychloroquine as compared to usual care. And so this really seemed like a settled issue by this point. However, quite recently, early in the summer, a study was posted on a preprint server, medRxiv. So this study was not peer-reviewed or published in the peer-reviewed literature, but it was posted on the medRxiv on the internet and got quite a bit of attention. It's an observational study on 255 very ill COVID patients who are on mechanical ventilation. And the authors here reported that patients who received a total of more than 3 grams of hydroxychloroquine along with azithromycin had a very, very substantially lower risk of dying than people who didn't receive as much hydroxychloroquine. However, when one looks at this paper, one realizes that to receive that total dose of more than 3 grams, patients had to be alive long enough to receive it. It wasn't as if patients on the first day got 3 grams of hydroxychloroquine. You had to be alive long enough to get it. So that they didn't survive because they received a high cumulative dose of hydroxychloroquine. They received a high cumulative dose because they survived. And in scientific terms, this is what is known as immortal time bias. And this analysis really is a classic example of this kind of error of immortal time bias. And this has been pointed out when journalists have tried to really get at whether or not this claim is true. So here you can see this posting on factcheck.org, where I and another physician scientist from the University of Minnesota both pointed out this really very basic error in analysis and noted that this study wouldn't get a passing grade in any beginning course in statistics and wouldn't survive peer review at a legitimate medical journal. Despite that, the obvious scientific flaws in the analysis, this study received quite a bit of attention in certain corners of the media that you can see here that have a particular political orientation, I think one would say, where this study was touted as showing a huge benefit for hydroxychloroquine and put forth as saying that hundreds of thousands of lives would have been saved if hydroxychloroquine had been used for the treatment of COVID-19 illness. But experts who've looked at this don't agree and haven't changed their guidelines for treatment of patients with COVID-19. So quite recently updated guidelines from the NIH for treatment of COVID say quite strongly that hydroxychloroquine should not be used for the treatment of COVID-19 illness, either in hospitalized patients or in non-hospitalized patients. So now a year and a half into the epidemic and a year after good randomized controlled trials started to come out saying that hydroxychloroquine really doesn't seem to have any effect, where are we? Well, that's really where we are. No convincing evidence has emerged that hydroxychloroquine has efficacy either in mild, moderate, or severe illness due to the SARS-CoV-2 virus. NIH, the World Health Organization, and other professional organizations recommend against its use in in patients with COVID-19 illness. Sadly, I think advocacy of hydroxychloroquine as a therapy is really an example, along with things like masks and vaccines, of the politicization of medicine and public health. This is something that is perplexing, confusing, and quite upsetting, I think, to those of us who are trying very, very hard to control this epidemic. Thank you very much for your attention.
Hello again, this is your host, Dr. Edward Halperin, with a word from our sponsor, New York Medical College. Putting programs on like the one you're watching today takes time, money, and resources, but we offer these programs for free, and we offer the CME credit for free. We hope, therefore, that some of you will be willing to make a tax-deductible gift to support programs like the one you're watching today and to help offset the costs of our COVID-19 research. Great things are happening at New York Medical College, and we hope you're willing to be a part of it. The way you can give back to the college is to make a gift by telephone by dialing 914-594-2720 and giving your information over the phone with your credit card information. You can go online at www.nymc.edu/give and fill out the information on the website to make a donation. Or if you'd like to write us a good old-fashioned check, we'll be more than happy to receive it in an envelope with a stamp on it by mailing it to the New York Medical College Office of Development, 40 Sunshine Cottage Road, Valhalla, New York, 10595. Make the check out to New York Medical College and write where you'd like the money to be designated to on the memo line of the check. Thanks for thinking of us during these challenging times. Everyone stay safe and healthy, and remember to put those questions that you have for our panelists in the question and answer box on the bottom of your screen, and let's go back to our program.
Whither cometh the booster? If, when, and how? I'm Dr. Robert Amler, and I have no conflicts to disclose. Let's consider the booster. What is this? It's an additional dose or doses that are needed periodically to boost the immune system. Here are some examples. We've all had these boosters, or most of them anyway, to boost our immunity to some pretty bad diseases. For COVID, what will determine the need for a booster? Well, the persistence of COVID, the persistence of effective immunity after the primary vaccine series, and certainly the emergence of variants in particular. More on that in a minute, but also geographic trends in the spread of the disease, individual factors, seasonal timing factors, and also population dynamics and the logistics of delivering a booster shot to hundreds of millions of people when we've already experienced difficulty in getting the primary series out there. Well, what about the variants? Viruses commonly mutate, as we know, and they create variants. For each variant, we need to learn so that we know the disease severity, the vaccine efficacy against that variant, the transmissibility, the responsiveness to treatment, and testing effectiveness. Well, here are the current variants of concern, a subset of all the variants that are out there. These are defined by the CDC as variants of concern, and you can see them by their WHO label using Greek alphabet letters, alpha, beta, delta, etc. And of course, we've heard the most lately about Delta, but there are many others out there. Most significantly, however, there are no variants of high consequence so far. High consequence being defined by the CDC and WHO as variants for which testing would not be effective, for which vaccine might not be effective, for which containment might be less effective because of rampant transmissibility and ineffectiveness of medications. So far, no variants of high consequence, which is good news. Geographic trends are also another factor in needing boosters. You can see with a relatively current map of the world that some places have really high prevalence of COVID right now compared to other areas. The need for a booster certainly could be higher in those areas, especially if we already have a highly vaccinated population. These are the hotspots, and they're going to be looking most closely at boosters. But there's also population dynamics, and we've all seen this map of the world with the traditional or the most common air routes that are flown around the world, with movements of population across continents, across oceans, and around the world, and the high density population areas. People crammed into streets, crammed into public transportation. Remember that metric that we talked about earlier in this series, the R naught, R sub zero. and how we said that this elegant but imperfect metric, R naught, is not a reliable enough predictor of what will happen during a pandemic like this. Because in some populations, like the ones we see, transmission is obviously going to be much more efficient than in places like this, where the chances of encountering a potentially infected person per day or per hour or what have you are, of course, going to be far, far less. It's the same Homo sapiens, but different contact rates with other individuals, and that too will determine the need for boosters. So far now, we defined immunity without boosters. Immunity is defined as fully vaccinated with the primary series greater than 2 weeks, or at least 2 weeks after completion of either the 2-dose or the single dose. And this is the definition of immunity as of the end of last month per the CDC. So currently the need and timing of boosters have not been established. And we might eventually bypass boosters entirely or eliminate the need for boosters if we can get the lasting protective immunity, often called herd immunity, that can be conferred by vaccination, by prior infection, but we don't know the percent that is sufficient. By the way, current deaths occurring from COVID in the US, 99% of deaths that are occurring currently are in people who are unvaccinated, according to the definition that we just looked at. So clearly we are not there yet, and we don't know if boosters will be needed. So what do we do now? While a booster may be likely someday, we all know that the mantra today and tomorrow for the foreseeable future is and will be get vaccinated. If anybody asks you, tell them to get vaccinated. Stay calm, watch the trends, and be ready to adjust. Thank you.
Hello, my name is Mil Etienne, Vice Chancellor for Diversity and Inclusion here at NYMC. I am also the head of the Health Equity Task Force for COVID-19 vaccine distribution in the Hudson Valley. I have no conflicts of interest. In the United States, the first vaccine for COVID-19 became available in December 2020, and we now have 3 vaccines available. These vaccines have made it possible to have large gatherings, both indoors and outdoors, with varying guidelines depending on location and the size of the crowds. Even before the vaccines became available, researchers at Goldman Sachs, in forecasting the return of the global economy, made predictions regarding the rate at which various countries would get vaccinated. They predicted that by now, about 60% of the US population will be fully vaccinated. In this article, they also commented that the demand for vaccines could be lower than expected if large parts of the population are reluctant to receive it. Considering this possibility, they made an additional projection accounting for vaccine hesitancy, which predicted that by now we would be at about 50% of the US population being fully vaccinated. Their accounting for hesitancy actually placed them right on target, because as you see here, as of this week, 49% of people in the United States are fully vaccinated. We are doing a bit better in New York State. As of this week, 62% of people living in New York State have received at least 1 dose of the COVID-19 vaccine, and 56% are fully vaccinated. Because of the decreasing demand in New York and around the country, the mass vaccination sites have been closing. Vaccine hesitancy is the delay in acceptance or refusal of vaccines despite availability of vaccine services. This is complex and context specific and can vary by community and by individuals. Common reasons for hesitancy include skepticism, complacency, convenience, and confidence, which can all interplay to contribute to an individual or community's vaccine hesitancy. We now have fairly good treatments for COVID-19, and we have seen a drop in the mortality rate overall. So some people may feel like they're unlikely to get it, and if they do get it, they're unlikely to die from it. There are others who believe they can still get to herd immunity without them getting the vaccine. It is important to keep in mind that many of the people who have vaccine hesitancy may still ultimately get the vaccine. Hesitancy does not mean vaccine refusal. Some of those statements may have been true if it were not for the emergence of the Delta variant, which spreads more rapidly and is more virulent than the wild type COVID-19. Numerous states have reported that over 97% of people being hospitalized because of the Delta variant are either unvaccinated or have incomplete vaccination. In order to overcome hesitancy, we need a better understanding of who is hesitant and why they are hesitant. After having this information, you can then devise strategies to target those hesitant communities. Many reasons people have provided for being hesitant include worries about side effects, mistrust of the government regarding safety, and some of this mistrust also relates to prior unethical experiments done on marginalized communities in this country. Others say they want to wait and see how the vaccine impacts others. Often the best messengers to help convince people who are hesitant about the vaccine are trusted members from those same communities. There is data showing that doctors are the most trusted source for vaccine information. Many of my own patients, particularly patients with chronic conditions like multiple sclerosis and epilepsy, have waited until they have their appointment with me to make a decision regarding the vaccine. It is important for people trying to educate these community members to know answers to commonly asked questions about the vaccines. Is there a tracking device in the vaccine? Concerns regarding sterility. Will I be sterile from getting this vaccine? Will my DNA be changed? When engaging these individuals, it is important to validate their concerns and then provide answers to their questions without skepticism. Providing clear and honest answers to community members can go a long way. It is important to make clear to community members that the vaccines were made using processes that have been developed and tested for many years. Our health, equity, and community engagement team in this region is uniquely positioned to reach all 5 hesitant groups previously mentioned. Our mission is to ensure an equitable distribution and administration of vaccines throughout the region. We have identified the communities with low vaccination rates, and we have devised strategies to increase those rates in those communities. This includes utilizing the coach unit that you see here in the slide to register people for the vaccines. This includes holding community conversations, both live and through virtual platforms like Zoom, WebEx, and other virtual platforms. And it also includes answering questions on a 24/7 hotline. Giving these community members accurate information at the time that they want it can go a very long way towards decreasing the vaccine hesitancy. In these community conversations, we often share with community members the diversity that was present in the clinical trials. This table shows the data for the Pfizer and Moderna vaccines. You can see that the diversity in the clinical trials approached that of the United States population across all races and ethnicities. Additionally, 25% of participants were from older age groups and people with conditions such as obesity, diabetes, heart and respiratory conditions. There were similar levels of diversity for the participants in the J&J Janssen clinical trials as well. We need to make sure that our institutions are trustworthy, transparent, and engage all communities. We have to listen to the communities and all the individuals in those communities regarding their vaccine concerns. If your institution does not already have a long-standing reciprocal relationship with these communities, you can start by engaging their leaders in those communities. This includes religious leaders, physicians, community centers like the NAACP, Black and Hispanic coalitions, YMCA, YWCA, United Way, barbershops, hairstylists, among others. Educate the community. Early in the pandemic, we stressed that wearing masks were not just for us, but also to protect other people, particularly our friends and loved ones. The same strategy can be used here. Get the vaccine to protect your loved ones who may not be able to get the vaccine or who may not be able to mount an appropriate immune response. Remember, it takes a village. Thank you very much for your attention.
Hello, this is your host, Dr. Edward Halperin, to tell you how to get your continuing medical education credit for those of you who are seeking CME credit from today's webinar. There are 3 ways to do it. You can text the code 90KYAK, 90 Kayak, KYAK. Text that code to 828-295-1144. If you send that text message, you'll get a response back with links and instructions as to how to fill out your satisfaction questionnaire with today's program and how to get your CME credit. If you don't like using that technique, go to the website www.eeds.com, click on the sign-in button, and similarly put in the code 90KYAK. And once you do that and click on the button, you'll get information for the questionnaire for your satisfaction with the webinar and your CME credit. If you want to use the high-tech technique, get that cell phone or iPad out with your app, scan the QR code, and you will similarly be taken to the correct site to get your credit. These codes will all expire on Monday, July 26th at 12:30 in the afternoon. So may I suggest you do your CME credit promptly, lest you forget. Also remember throughout our program, if you have any questions for our panelists, please type them in the question and answer function on the bottom of your screen. We'll be monitoring them throughout the webinar, and we'll get to as many of the questions as possible during our question and answer period. Let's go back to our program. Hello again, everyone. This is your host, Dr. Edward Halperin, the Chancellor and CEO of New York Medical College and the Provost for Biomedical Affairs of the Touro College and University System. We have had in these webinars over the last year and a half, for the most part, presentations by our panelists with slides, but those of you who have been faithful attendees of our programs will remember that from time to time, we have interviews interspersed in our program. We have in the past interviewed the Chief Medical Officer of Westchester Medical Center, Dr. Renee Garrick, the Chief Medical Officer of Metropolitan Hospital Medical Center, Dr. John Pellicone, about their experiences during the pandemic. And for the next part of our program this afternoon, we're going to have an interview with Joshua Ratner of Westchester Medical Center and WMC Health to talk about the perils and pitfalls of being an administrator of a hospital during a pandemic. Mr. Ratner, thank you for joining me this afternoon. And let's start, please, if you would simply tell the audience who you are and what you do and what your job responsibilities are. And for the people who are tuned in with us from around the United States and the world, what's Westchester Medical Center and WMC Health?
Well, first, thank you, Dr. Halperin, for inviting me to participate this afternoon. As you said, my name is Josh Ratner. I'm the Chief Strategy Officer and Executive Vice President for WMC Health. WMC Health is the health system that incorporates 10 hospitals that are dispersed across the Hudson Valley. We have in Westchester County, we have Westchester Medical Center, we have Maria Frari Children's Hospital, and the Behavioral Health Center in the Westchester campus. In Poughkeepsie, we have Mid-Hudson Regional. In Ulster County, we have the Health Alliance hospitals. In Delaware County, we have a critical access hospital called Margaretville Hospital. And then across Rockland and Orange, we have 3 Bon Secours community hospitals that are all along the New York-New Jersey border that span both Rockland and Orange County. My role is both focused on a global or network-wide scope, as well as the individual hospitals as needed. And what my scope of responsibilities include strategic planning and business development for the network, but also include operational responsibilities for the behavioral health services across our network, clinical research, grants, marketing and communications, as well as community outreach and patient experience, government affairs. So I have a host of various responsibilities. And I think that from my perspective, at least, It's unique, and it's a great opportunity to be able to look at how can we look at a patient experience before they even touch the network, all the way through, and on the back end, how do we maintain that relationship? And that's part of what our focus is as a network today.
Thank you. For those of you not immediately familiar with the counties and locations Mr. Ratner has talked about, for our purposes of our webinar, you'll remember that for a while, the epicenter of the pandemic in the United States was a place called New Rochelle, New York. And New Rochelle, New York is in Westchester County, New York. And so, to cut to the chase, we are talking therefore with a hospital administrator of the frontline hospital at the center of the pandemic when the pandemic came to the United States in 2020. So let's assume that you and I have stepped into a time machine, and now we have been blasted into the future. And this interview has taken place before a group of earnest and excited 23-year-old graduate students who all want to get their MHA in hospital administration. And it's Q&A time, and one of these graduate students raises their hand and says, I read in my history book, in the history of hospital administration, that there was something called a pandemic in 2020, 2021. And I see that although you have a lot of gray hair now, sir, that you must have had dark hair back then, and you were apparently a hospital administrator in the middle of this pandemic. Can you tell me what you think the most important thing was you did in the middle of this pandemic to keep the place running? What's the smartest thing you did about managing the hospital and the health system during the pandemic?
Wow, that is a fantastic question. I love the premise, and I'm excited to be in the classroom with all of you. So I think from my perspective, none of us had any experience. I'll speak personally. I'll speak on behalf of myself. Have not had an experience with a pandemic. We've read about it in the history books, but living it, if I were most proud of what we were able to do and what we were able to accomplish as a health system, we rewrote the rule book. When you think about where we were, whether it was New Rochelle in those first couple of months, all the way through that first year, we really, as a management team, had to recreate, we had to throw away the existing rule book of how to run a hospital and create a new one. And what that meant was in some very specific and tangible examples. Let me give you a couple. Here's an example. We had just finished completing, the building that I'm sitting in is an ambulatory care pavilion. It's a beautiful new addition to the Westchester Medical Center campus. We have the various hospitals that I told you about, including pediatrics and behavioral health, but we're very used to running a full hospital. We have a very high acuity of the patients that come here. We got a lot of transfers from area hospitals. When the pandemic hit, we quickly had to recreate how we care for patients to ensure that we had both capacity, safety, and quality. And so what that meant was we created essentially two hospitals within a hospital. We had to stop all elective procedures and surgeries. We had to convert essentially what was an ambulatory care pavilion into a non-COVID hospital. And we had to convert our hospital into a COVID hospital. So we were running two separate hospitals under one roof. And that's something that we've never, nor has that I'm aware of, anybody ever had to do that in the last 100 years. Our ability to effectively put policies and procedures in place, we had to rewrite the regulations and policies. Don't forget that visitation was an issue, PPE was an issue, working with the Department of Health and the departments of OMH and the governor's office to look at what are the new rules and regulations. As an example, someone on my staff almost on a daily basis was drafting and sending memos to the state to say, hey, we've moved X service from this unit to that unit. In New York State, we're highly regulated. We're what's called a certificate of need state. So anytime you need beds or you need to change services, you've got to go through a pretty thorough process. This was one of those examples where there was no CON, but how do we know what was moving from X to Y? So we had to basically retool our entire operations and track it on a daily basis to make sure that we were in line with where the state regs were, because the state changed their regs almost on a daily basis, but also to make sure that we knew exactly how we were caring for patients on a daily basis. And the other thing I would say, in addition to the 2 hospitals under one roof, was we created really new venues. We created new venues to care for patients. In some instances, that could have been a drive-through tent where patients could come and get COVID tested. And today I'm proud to say that that tent is now a building, and we're doing not only COVID testing, but vaccine distribution. Or it could be staffing mass vaccination sites to make sure that as much of the public as possible can be vaccinated. So when you take a look at the full breadth of what we were able to accomplish, really rewriting that rule book in an industry that's so highly regulated is one of those areas that I think is a shining example of what we were able to accomplish as an organization.
The student looks puzzled and has a frown on their face and says, I'm not sure I understand. It says in my history book that a bunch of politicians said we're going to take a place called the Javits Convention Center, which is apparently now a ruin in New York City, and the Westchester County Center, which apparently doesn't exist anymore, and make those COVID hospitals. And there's a picture here of some kind of Navy ship that the president was talking about. So why were you making 2 hospitals if all these politicians were talking about this? Did that stuff make any difference?
Wow. So yeah, I think it's very easy now to look back and say, you know what, those probably weren't as effective as we thought they might have been at the time that those were put together. You know, and there's some Monday morning quarterbacking that happens, right? When you look at it and go, okay, so what was the intent and how many patients did it really serve, right? In the case of the ship, right? Nobody. In defense of our elected officials, I will say that, and it was true for all of us who were dealing with it, we were, at the time those were created, we were looking at an enormous number of COVID patients. We were challenged with ventilator status, with PPE, and we didn't know where the top of the peak was. And our elected officials and our politicians said, we're going to need enhanced capacity because there's only a limited number of hospital beds. And if this continues to grow, we're going to have a problem. So, you know, to their credit, doing nothing wasn't an option. In hindsight, would we have done it differently? I think the answer is yes. But I think it's very easy when you're outside of a pandemic to reach those conclusions. I will say that in being involved with many of those conversations at a state level, they had the best intentions in mind and making sure that we were prepared for whatever was coming next.
Another student on the other side of the room raises their hand and says, I have aspirations after I get my degree to end up as the chief of HR, human resources, when I graduate. Can you teach me anything about how you had to manage personnel in a crisis situation that you think is worth knowing?
Yeah, I think there's 2 key elements when you're living this. And for you, the student who's really trying to look into what it means to be a hospital leader or hospital administrator. And in this particular example, sticking with a pandemic as the example, as you just asked, everybody is anxious. I think everybody has the right intentions. Our staff are all trying to do right by patients. As a leader, there's a couple things. One, and this may sound very obvious, so pardon it, but you have to lead by example. We had staff that were sleeping on cots in their offices, that were stretched beyond belief in terms of their scope and control. We had an incredibly dedicated workforce. As a leader, we needed to be visible. The folks needed to see us, and it wasn't just a 9-to-5 job. You had to lead by example. So I would say number 1 is be present and really help support your workforce in any way that you can. The second thing I would say is you really have to, as a leader, lead. And so what that means is you have staff, you have management that work with you, and even your frontline staff. Listen to as many people as you can in terms of what's happening on the ground, what are the conditions, take as much input as you can. But at the end of the day, you have to make a decision, and then you have to be able to lead that decision through operationalizing it. And as a leader, sometimes that, as somebody looking at leadership, sometimes that gets lost. Somebody has to make the decision. And just because you're a leader doesn't mean you should just make the decision. You should bring as much input as you can into the decision-making process. But making that decision and executing is really more than half the job. And I think that when you look at a pandemic like we were just living through, and then you're using the example of the mass casualty sites as an example, that is one of those areas where you look at it and say, okay, what were the folks on the ground telling us at the time, and what might we have done differently if we had listened to them at the time? And one of the things we heard was, hey, we aren't getting a lot of non-COVID patients. Originally, some of those sites were set up as a decanting facility to take non-COVID patients and move them to make room for COVID patients. Well, in a lot of hospitals, there really weren't that many non-COVID patients. So that probably could have been better informed in terms of a strategy. But that's just one example, I think that came to mind.
Well, the students burst into spontaneous applause. They've been fascinated by it, and the professor decides that this is a lot easier than giving a lecture, so invites us back to come to class again a week later. And we get back in our time machine and come back to the present, where I get to say thank you for talking with me this afternoon and for sharing your thoughts with the attendees at our webinar. Remember, everyone, if you have questions for Mr. Ratner or for any of our speakers, type those in the Q&A function on the bottom of your screen. And now let's go on to our next panelist. Thank you, Mr. Ratner.
Thank you again.
Hello, I'm Nicholas Janiga, Vice President and Chief Legal Counsel at New York Medical College. I'm talking today about court decisions and administrative rulings related to mandatory employer vaccinations. I have no conflicts of interest to declare. I do have an obligatory disclaimer that I'm a lawyer, but I'm not your lawyer. So this is a brief overview, and you should discuss your details and your facts with your lawyer before taking legal action. I spoke in late May during our last COVID webinar, and I discussed how employers may mandate vaccines and identified some considerations caveats. I'll cover several key developments since our last webinar. An organizational point that throughout this slide, I used the tiny URL version, if you're not familiar with, to refer to documents you may want to refer to. In your notes, you can simply identify the shortcut of the last few initials, put it into this link, standard link format, tinyurl.com, and you'll be taken to the original document. The first stop along our way is the U.S. Equal Employment Opportunity Commission. The U.S. EEOC is the authority to investigate charges of discrimination against most employers. Employees often must file a formal complaint with the EEOC before initiating lawsuit against employers. An EEOC can choose what level of investigation to do. However, even if something doesn't run directly afoul of the law, the investigation process can be onerous for employers. In late May, the EEOC issued technical guidance directly addressing the vaccine issue. While this is not legally binding, the guidance does set important parameters for when the EEOC may or may not take issue with an employer's vaccine policy. The EEOC published a question and answer format on May 28th, and I draw your attention to 3 questions of relevance. In K1, the EEOC unambiguously stated that vaccine mandates with reasonable accommodations do not violate federal EEOC laws. This is a very clear direction that the EEOC does support mandatory vaccine policies. However, in K6, they noted that it is unlawful for an employer to disclose that an employee is receiving a reasonable accommodation. This really impacts practical elements of a policy you may put in place. You should not have badges or other outward signs that directly state that someone has been accommodated and therefore they're not complying with the mask vaccine policy. Yet you may need to differentiate for activities, masking, or other behaviors between vaccinated and unvaccinated individuals. One way to do this is to offer, not mandate, that individuals who have proven vaccination status to you have outward signs and may take a sticker or a badge to show that they have been vaccinated. You should not mandate this because there are issues with any mandatory indicators of health confidentiality and otherwise. However, employees who do make their own choice, that they have shown you that they are vaccinated and choose to show others that they're vaccinated, You can treat them differently, perhaps with more lax procedures consistent with public health guidance, separating and treating vaccinated and unvaccinated differently. And then anyone that for any reason does not have that sticker or other site should be treated with a stricter unvaccinated approach. I also flag question K16 on our last presentation. The EEOC, I talked about employer incentives. The EEOC gave the green light to this carrot and stick approach, the carrot side, that you may decide to do incentives for people that do comply. Another development involved litigation activity in Texas. The Houston Methodist Hospital System, with 20,000 workers, announced in March that it would require vaccines for all of their employees. They were an early actor with a very defined policy that did permit religious and medical accommodations. On April 1st, 117 of their employees filed a federal lawsuit objecting to the policy. The plaintiffs argued that the policy required employees to be a human guinea pig and that current vaccines are experimental and dangerous. They likened it to the Nuremberg Code and forced medical experimentation. On June 12, 2021, their case was dismissed in a succinct 5-page order by a federal judge. I encourage everyone to go and read that brief cite. The judge rejected the wrongful termination claim under Texas state law. The claim that current vaccines are experimental and dangerous, the judge said, is both false and not relevant to a wrongful termination claim. The judge rejected that a private employer who mandates use of the vaccine under the emergency use authorization in any way violates federal law. There's language, people that are familiar with the EUA authorization, talking about the options to individuals that are taking this vaccine. The judge went on to talk about that it is voluntary, it is not forced, even if an employer is offering this up. The judge rejected the comparisons to the human trial and the Nuremberg Code arguments, calling them reprehensible. And the judge clarified that these employees have a choice. They can choose to accept that vaccine, or they can choose simply not to, in which case they'll have to find somewhere else to work. And indeed, on June 22nd, there was a press release that 153 Houston Methodist employees made that choice not to take the vaccine and either resigned or were fired for their refusal. The hospital system of 20,000 employees, 153 represents 0.75%. You obviously may have to think about the reactions of your employees when you are applying this to your size institution. We shouldn't forget about the states. Wrongful termination is a state law claim. So the answers in the Houston Methodist case related to wrongful termination are limited to Texas law. There is the possibility that that claim under different state laws may create other situations, even in facts similar or identical to Houston Methodist. As of my last count a few weeks ago, there were 32 bills across 25 states impacting vaccinations. Some bills have failed, many are pending, and some have become law. In Arkansas and Utah, there are prohibitions on state and local governments and government employers requiring proof as condition of employment. In Florida also has this, and it applies broadly to private and public employers. An interesting and unique issue is that currently the guidance is in Florida law, employers may require employees to be vaccinated. However, it's the honor system, and because employers are prevented from requiring employees that identify as vaccinated from showing any type of proof. You may want to follow along. The National Conference of State Legislature has a website tracking legislative activity as these decide to ebb and flow with state legislative sessions. Since the last presentation, a number of employers have publicly announced vaccination mandates with icons on the screen. Some notable are New York Presbyterian Hospital System, Yale University, Saks Fifth Avenue, the Broadway production of Hamilton. Delta and United Airlines have announced a policy, but currently apply it only to new hires, not current hires. My predictions for the future, I do expect future litigation activity to be focused on the issue of denials of exemptions, both medical and religious. A Queens, New York couple has filed suit after their New York employer terminated them and refused to grant an exception. They were trying to get and are trying to get pregnant. They're not pregnant yet, and the employer did not grant an exception for that. Boston College is in the news recently for refusing to grant religious exemptions to Catholic students who are objecting to the impact and use of fetal tissue stemming from previous abortions, either in the testing or development phase of these. This is notable. While the Roman Catholic Church is staunchly against abortion, the Pope and the Vatican have both said that it is not against the Roman Catholic faith. And that's currently how Boston College which is founded in the Jesuit Foundation, a division of the Catholic faith, is following through and making these divisions. Parents have said that they have multiple college-age children, with some colleges granting that as a basis. And when Boston College is not, it's creating some consternation. So stay tuned to this space. We'll be watching. There'll be more litigation and other state legislature activity. Thank you very much.
Hello again, this is Dr. Edward Halperin, your host, to talk to you about giving back to New York Medical College. Programs like the one you're watching today cost the college time, money, and effort to put on, including giving free CME credit, which of course is not free for us to provide. We hope that many of you will consider supporting the college by making a tax-deductible gift. Your donation will help offset the cost for our students providing scholarships or supporting research or supporting this program. We're happy to designate the gift wherever you'd like it to go. Great things are happening at New York Medical College. We hope you'll choose to be a part of it. So please make a gift by calling 914-594-2720 and talking to one of our friendly development officers who will be happy to take the credit card information over the phone, and you can tell them where you'd like your gift to be directed, or go to our website, www.nymc.edu/give, and provide the information there for your tax-deductible gift, or write on the memo line of your check where you'd like the money to go, whether for COVID-19 research or to support the webinar or for scholarships. Make the check out to New York Medical College and put it in an envelope with a stamp on it and mail it to New York Medical College, Office of Development, 40 Sunshine Cottage Road, Valhalla, New York, 10595. Thanks for thinking of us during these challenging times. We hope everyone stays safe and healthy. And now it's time to begin the question and answer portion of our program. So we welcome our moderator for the question and answer program, the president of the Touro College and University System, Dr. Alan Kadish. Dr. Kadish.
Thank you very much, Dr. Halperin. We've actually had an unusually large number of questions at this webinar. First question is for Dr. Ambler. It's a very practical question. Hearing that people who are vaccinated can still become infected. My niece has a baby shower. She's 5 months pregnant, baby shower coming up. And the question is, should she allow unvaccinated people to come to the baby shower? What are the risks? And how should we handle that?
That's a really excellent question. Thank you for sending it in. You know, many families this summer are resuming their plans for weddings and baby showers, wedding showers, bar mitzvahs, and so forth. And this question is coming up all summer long. In this case, the niece is vaccinated. She's considered immune, although we know that some vaccine failures will occur in, let's say, between 1% and 5%, maybe a little bit more. So is it possible for her to get infected if she gets exposed? It is certainly possible. Will she have a severe illness? It's not easy to say. When people are pregnant, they are more likely to have severe illness, but when they're vaccinated, they're more likely to have less severe illness. Since this is an individual, personalized question about what she wants to do, whether she wants to have the baby shower, whether she wants people to come or she's concerned, she should discuss it with her physician who's monitoring her pregnancy, and also discuss it with family members to decide what she will be comfortable with in terms of her own acceptance of some unquantifiable risk. Thank you for that very interesting question.
Thank you, Dr. Ambler. I have a second question for you. Does a medical history of allergy-type reactions to contrast dyes used in CAT scanning or MRI scanning represent a contraindication to COVID-19 vaccines?
Not a contraindication, but people who've had severe allergic reactions called anaphylaxis to any component of either an mRNA vaccine or the Johnson & Johnson COVID vaccine, which is a viral vector vaccine, should not receive that vaccine if they are concerned about those components They should speak again to their personal health care provider to decide what needs to be done. A severe allergic reaction is a serious condition, but so is COVID infection. And if they can be safely vaccinated, that is always the better option. Thank you for that question.
Sure. And one last question for both you and for Dr. Schluger. I'm going to take two questions that have been asked and kind of put them together. It's about someone who's already had COVID-19, and the dual questions are, first of all, if you have antibodies, should you still be vaccinated? And if you've had an infection, do you need both doses of vaccine, or is one dose enough?
Dr. Schluger?
The current recommendation is that persons who've recovered from acute COVID-19 illness should in fact still be vaccinated. We generally recommend that people wait 90 days after they've recovered from their acute infection to be vaccinated. There seems to be no particular risk associated with that vaccination. Previously infected people who get vaccinated tend to make very high levels of antibodies in response to vaccination. So I think in general, we have been recommending vaccination. No one really knows how long so-called natural immunity lasts after an infection without vaccination. So I think I have recommended to patients of mine and family members, people I know. Actually, I shouldn't say that. Fortunately, none of my family has had acute COVID illness, but many friends. So I have recommended in that situation. And whether or not you need one or two doses, again, I don't think we really have good data about that. I don't see any particular harm in getting the full series of vaccine. If you get Pfizer or Moderna, it would be two. If you get the J&J, it would just be one.
And I basically agree. The issue really, as Dr. Schluger alluded, is we really don't have a firm definition or a firm view of the lasting immunity and the effectiveness of immunity following wild infection with wild virus. What we also don't fully understand is the long-term immunity outcome from vaccination, from the 2-dose series or from the 1-dose. So we are basing what we say today on empirical observation and not controlled investigation. Thank you for that question.
Sure. Thanks to both of you. The next question is for Dr. Bakshi. Are there certain conditions that make virus, either the COVID-19 virus or viruses in general, more likely to mutate? And are there public health measures that can affect the rate of mutation or the prevalence of variants of the virus?
So thank you so much for this excellent question. So yeah, any condition that can reduce the spread of the virus will reduce the emergence of variants. Because this virus is continuously replicating, and because this is an RNA virus, so it's also mutating. So the widespread transmission of this virus allow for the selection of the best mutant, which is fit for a higher rate of transmission, as well as cause the severity of the disease. So any measure, that can reduce the spread of the virus will also reduce the spread of the emergence. And this was to some extent was achieved when the lockdowns were imposed, or we are maintaining social distancing. But now with the availability of the vaccines, so the vaccinations are the best tool. And as I've shown you in my presentation, that the vaccination are capable of reducing the severity of infection by more than 90%. So the best way to avoid the emergence of variants, and the best public measure, that we can take is to get more and more people vaccinated and prevent the spread of the virus. Thank you for this question.
Sure. Second question for you. How would you compare the efficacy of the 3 vaccines available in the United States, Moderna, Pfizer, and Johnson & Johnson?
So basically, if we look at the efficacy of Pfizer and Moderna, actually, both vaccines have shown a very high efficacy, 94 and 95% in preventing the symptomatic COVID infection. But these vaccines, cannot be compared because there were some differences in the design of their clinical trials. And especially Pfizer and Moderna vaccines were tested when the variants were not that common. And the Johnson & Johnson vaccine, is tested in a lot of countries where the variants are common. So basically, because of the differences in the design of the clinical trials and the outcomes that were determined, with like what outcomes were kind of kept for determining the efficacy of the vaccine. So it's very difficult to make a comparison between three vaccines. But as far as I can see, I can say that both Moderna and Pfizer vaccine are highly efficacious in protecting people.
Thank you. What about the other vaccines that are being administered worldwide? Do you think they're as effective as these three?
So again, like one of the studies that is done in England, they have compared AstraZeneca vaccine with Pfizer. And it turns out that the Pfizer is superior as far as the efficacy of protection is concerned against Alpha variant and against Delta variant as well. So yeah, but again, the comparison is very hard to make because the parameters that were selected for the clinical trials may be different for one vaccine as compared to the other one. So, yeah, so, thank you.
So Dr. Schluger, if I could ask you to weigh in on some of these comparisons as well. Of the 3.7 billion doses of vaccine that have been administered worldwide, many have been the Chinese vaccine, particularly Sinovac, the Russian vaccine Sputnik. What do we know about the efficacy of those vaccines compared to vaccines that are being used in the United States or AstraZeneca?
Right, good question. There was a paper published in The Lancet that looked at the efficacy of the Sputnik vaccine and suggested that that vaccine had quite good efficacy, at least against the parent strains, the wild type, common wild type strain of the virus. I haven't seen too much data since that original Lancet publication about the Sputnik vaccine, but certainly the original data look good. There have been many, many more questions about the Chinese vaccines. There have been relatively few data published about them, and some data that has come out about the Chinese vaccines suggests that they may be only about 50% effective. 50% is not nothing. The influenza vaccine that we use year after year in most years has efficacy about 50%, but certainly in the context of the other available SARS-CoV-2 vaccines, particularly Pfizer, Moderna, and J&J, 50% efficacy seems far from optimal. So I think that's the sort of current state of play about those vaccines.
Thank you. Next question is for Mr. Janiga. At the last webinar, you talked about vaccine mandates for students, and you gave us some updates about vaccine mandates for employees. Are there any new court cases that have talked about or legal developments about mandatory vaccination for students?
Thank you, Dr. Kadish. Actually, yes. In addition to the Boston College actions I spoke about, this past Monday, a federal judge in Indiana upheld Indiana University's vaccine requirement. So Indiana University is a public university, so a state actor that involves some additional constitutional elements that are not applicable to private universities. Indiana University created a fairly standard vaccine mandate for the campus community, all students, faculty, and staff. It included a process to approve medical and religious exemptions. 8 students filed a legal challenge, and they invoked many of the common objections that we've heard from people against the vaccine, the fact that it's only an emergency use authorization, that the vaccine is too new to be safe, that constitutional rights are being violated by forcing them to make decisions about what to put in their body, and the students' assertion that spread risk is low on college campuses. So the judge issued a detailed 100-page opinion and held essentially that the public's health interests for the campus community supported a vaccine policy, even balancing against what he said, the significant rights of students to refuse unwanted medical treatment. In the lengthy discussion, he explored the issue of constitutional protections. He addressed and talked about the university's science-driven process, including buy-in from campus stakeholders. He described masking and testing requirements that the students also objected to as trivial inconveniences and not intrusions on constitutional rights. So this was a significant move towards institutions upholding vaccination policy. However, I note that this was just a request for a preliminary injunction. So in legal speak, it's a different legal process that's shorter than full litigation. An appeal is expected of this, so this won't be the last judge to weigh in on university vaccination policies, but it is a very meaningful step. Thanks for the question, Dr. Kadish.
Thank you very much. So as a follow-up to that, to Dr. Etienne, what Mr. Janiga has told us is that it's probably legal for schools to require mandatory vaccination. But the question that was asked is, why not just let people choose not to be vaccinated and suffer the consequences? It's their body, isn't it?
Yeah, thank you for that question. Yeah, definitely, challenging. So we know many schools are, mandating the vaccines for their students, and obviously by having the vaccines, this allows the students to be able to see each other face to face, see their friends, colleagues, teachers, professors, and it also helps protect those professors and teachers from having the COVID infection. In these situations, we're thinking about, medical ethics. So you brought up the concept of autonomy, the person making their own decision regarding whether or not they should be vaccinated. But the other tenets that this conflicts with are the tenets of justice, beneficence, non-maleficence. So the supreme tenet in ethics is first do no harm, or primum non nocere. And by having people get vaccinated, you're helping to protect, you're basically serving the greater good, saying that we're gonna keep lots of people from being infected, to allow us to actually carry on business, protecting those, particularly those older teachers, professors. But definitely, these are tough questions, especially when we're talking about medical ethics. Thank you for that question.
Thank you, Dr. Etienne. Follow-up, a second question for you. Do you think it's safe to vaccinate people with multiple sclerosis or other autoimmune diseases, both neurologic and general?
Yes, thanks for that question. Absolutely. Our patients with multiple sclerosis, we have been recommending that they get the vaccine. The American Academy of Neurology has supported that. But what I say to patients in general is, if you've got a chronic neurological condition, it's a good idea to consult with your neurologist sooner than later. Just this week, one of my patients who has MS had been, you might have classified her as hesitant. Keep in mind, when people are hesitant, that doesn't mean that they'll never get the vaccine. She just wanted to get more information from her doctor. And after we discussed the pros and the cons of the vaccine, she made a decision that she would go and get the vaccine. But she, for a patient with a chronic condition, their doctor knows them best. And so a lot of times they don't just want generic advice or generic information from people who don't really know them or know and understand their bodies. So that's why it's very important that we consult with our physicians in these situations.
Thank you very much. So I've received a number of questions about Touro's policy regarding vaccination and our campus opening. So let me try to first, before answering the specific questions, just summarize what we've elected to do. First of all, at New York Medical College and at Touro, we expect campuses to be open in the fall, and we expect most activities to happen in person. We do have vaccine mandates in place. The vaccine mandates are hard mandates for New York Medical College and other health science schools at Touro, and a little bit of a softer mandate with some exceptions for the non-health science, non-public facing students at Touro, meaning that you can elect not to be vaccinated, but you have to mask, socially distance, and be tested frequently. That's similar actually to what's been announced by a number of other institutions. So Touro and New York Medical College do plan to be open fully in the fall. We do plan to try to create a safe environment for students and faculty. We have had a few people who've been very resistant to the vaccine mandate, and we're trying to deal with those cases, and we understand why some students and faculty, but it's students in particular, may be concerned about side effects from vaccines. But what I'd like to point out is a couple of things. COVID is not done. number of cases in the United States has increased several fold in the past few weeks. The R0, which we talked about recently for the Delta variant, which is now the majority of US cases, is higher than it was previously. People continue to die at major rates from COVID. And when you've administered 3.7 billion doses of vaccine worldwide, it's not surprising, as with any medical therapy or any vaccine, that there are a few side effects. And looking at videos of those few side effects and not doing the right thing that's data-based, which you've heard today and at prior webinars about how effective and generally safe the vaccines are, we think as an institution is not the right way to go. And that's why we've instituted vaccine mandates, although, as I mentioned, in the non-public facing, non-health science programs, with some exceptions. And we believe that's the best way to get campuses open, to keep people safe, and to support the public good. We're not alone. Hundreds of universities around the country have announced vaccine mandates. In fact, our policy is actually more flexible than at many places. And we feel that we're doing the right thing for our students, for our staff, for our faculty, and for public health in general. There was a question also about the fact that Touro is offering gift cards to those people who've documented compliance with vaccination. And some have objected to that as being a form of bribery. We feel that it's a form of thank you for doing your public good. It's an amount, $100, that's not dramatic, but it's a way of thanking people for cooperating. And it's part of a federal program to encourage universities to help support vaccination. So that's what Touro is doing. And we hope to have a successful and safe fall semester for our students, faculty, and staff. Dr. Schluger, a couple of additional questions for you about lifestyle measures in terms of helping preventing COVID, both lifestyle measures in general and things like vitamins, antioxidants, zinc. Do you think, is there any evidence that any of those therapies or lifestyle factors might affect the spread of COVID?
Well, it's certainly true that being healthy overall seems to be useful in coping with a lot of infectious diseases. You know, we know that, for example, obesity has been identified as a significant risk factor for mortality in patients with COVID illness. And so leading a healthy lifestyle, not being overweight, things like that, in general, seem to be beneficial to people who become sick with COVID or any other acute infection. On the other hand, there's not really convincing data that would suggest that specific individual therapies or supplements or vitamins are particularly useful, whether it be vitamin C, vitamin D, or other antioxidants. There have been a whole host of trials, for example, of vitamin D in a whole variety of illnesses. And I'm not really aware of any convincing data in the vast majority of them that suggests that vitamin D protects against infectious diseases. As I said, really in a convincing way. There's a little bit of data in diarrheal diseases in children, but for the vast majority of infectious diseases, not too much evidence that things like vitamin D and vitamin C are really protective antioxidants as well. And these have been studied in a whole variety of illnesses. So I think, you know, generally leading a healthy lifestyle is a good thing to do. But if the best thing to do if you want to prevent yourself becoming ill or even dying from COVID is to be vaccinated. Thanks.
And the last question is also going to be for Dr. Schluger, at which point we'll run out of time. Do you recommend therapy for people who have prolonged vaccine reactions, such as headache and other symptoms? Is there anything that can help in those circumstances?
Yeah, I mean, I think the good news is that the vaccine in general is extremely well tolerated, and after 24 to 36 hours, most people feel fine. As with all vaccines, there are occasional side effects. I think people have seen some concern about a small number of cases of people who might have a Guillain-Barré type syndrome after the J&J vaccine, for example. But most people have side effects that last only a very short period of time. And we've generally been recommending to people that they treat themselves with the usual kind of anti-inflammatories, acetaminophen or non-steroidal anti-inflammatory agents, and that will generally do the trick.
Thank you very much.
Certainly, if there's a concern about something like Guillain-Barré, someone should seek medical attention. Sorry. Thanks very much.
No problem. Thank you, Dr. Schluger. Thanks to all the panelists and Dr. Halperin for another great session. COVID, unfortunately, looks like it's going to be with us. So while we'd like to meet under other circumstances, we should see you again in a few weeks for an update on where things stand and how we can finally overcome the pandemic. Thanks again, everyone, for listening. Thanks for a lot of great questions. Sorry we didn't get a chance to answer them all, but we look forward to seeing you again in a few weeks. Take care.